My name's Delane Smith. I'm the CEO of the Australasian Leukemia and Lymphoma Group, which is a doctor volunteer organisation that develops clinical trials for patients with blood cancers. And just before we get started and talk a little bit more about the group and everything, I would just like to acknowledge the Aboriginal and Torres Strait Islanders people of Australia, the Maoris people of Aotearoa, New Zealand, and the Indigenous peoples of countries where its members and stakeholders live and work. We're hosting this meeting today on the lands of the Gadigal people of the Eora Nation, and we pay our respects to their elders, past, present, and future leaders. So thank you all for being here today. Just a couple of little housekeeping steps. I'm sure everybody's familiar with these kinds of things now. And then today's program, so as my good colleague Erica said, this is a joint program of the Australasian Leukemia and Lymphoma Group with Lymphoma Australia, which is Australia's premier patient support group for patients with all types of lymphomas. And we're going to keep the session pretty light as you can keep clinical trial discussion. And we'll have a couple of speakers. We'll have today some Lymphoma Australia representatives as well as the ALLG. So perhaps, Erica, maybe I'll just bring you back to do the complete introductions. I'll be around the whole session and I'll certainly be available afterwards for any questions and answers that anyone would like to follow up throughout the session. Thanks, Erica.
Thank you. All right, so before we get started, I'll just finish my proper welcome. So I'd just like to take this moment as well too to acknowledge why we're all here as well too, and the commitment that you all have to, I suppose, enhancing this and empowering yourselves as well too. I think that events like this really give you the opportunity to have that information that can make a difference and improve your experience throughout all of this. So we've come together to create this platform, not just for education, but as I said, to empower you all as well. So we understand that navigating the complexities of healthcare and lymphoma can be very challenging, both for you and your loved ones as well too. So I recognise that there's quite a few carers in the room as well too. So these sessions have been designed specifically with experts here to give you some of that most up-to-date information to help you navigate this path and also to help understand clinical trials as well. So welcome, and let's get started. So I want everyone to engage as much as possible, ask your questions, share your experience, engage with each other and share your stories as well too. This is an opportunity for support for all of you, and things like this don't come along very often as well too. We always, every time I say we're doing something in one state, everyone goes, but what about over here? So take this opportunity and connect with each other as well in a nice environment where you have similar experiences as well too, and see what you can get back from each other. So our first session, it focuses on wellbeing through treatment and beyond. So in a recent study, only 30% of patients who were diagnosed with lymphoma actually felt supported in their emotional experience through their journey. And I'm not saying that to you because I think that you're unaware of the challenges that you face. I'm saying it to you because I think it's really important to acknowledge that you're not alone. If you're struggling, there is support out there. And this is a difficult journey. So this is why we have people like our next speaker, Tony Lindsay, who's here today. So I will introduce Tony officially. So Dr. Tony Lindsay is a clinical psychologist who has been working with both adults and adolescents in an oncology setting since 2007. She works at the Chris O'Brien Lifehouse Centre in the oncology service and is a specialist in the care of adolescents and young adults with cancer. Tony teaches in the Department of Adolescent Medicine at the University of Melbourne and the University of Sydney Nursing School. She is the chair of the International Psycho-Oncology for adolescent and young adult cancer care groups and is actively involved in several multi-site research projects. She's also a published author with several books, including The Certainty Myth, Cancer, Sex, Drugs and Death, and The Cancer Companion. And they're all about the acceptance, the use of acceptance and commitment therapy. Welcome, Tony.
Little green button.
Little green button.
Excellent. Don't press the big red button would be my guess. So thank you all for coming. I was just chatting with Erica before saying it's so lovely to be in a room with people together. I'm not sure whether you guys are having, I imagine you are having a similar experience. We've been in a funny space over the last couple of years where lots of the stuff that we would normally do face-to-face and in rooms with people kind of ended up on screens, and my guess is you guys have been having the reverse experience of that. And so it's actually just really lovely to be in a room with people. Before I start, I would also like to acknowledge the land on which we meet, the Gadigal people of the Eora Nation, and their elders past, present and emerging. So what I thought I would talk about today, and as per Erica's point, I'm happy to be derailed, and anyone who knows me knows that that's actually not a particularly challenging endeavour, is this idea of how we manage through treatment and how we manage past treatment. Is actually a really complex psychological space. And one of the things that I've actually noticed in my practice is actually when people are on treatment, they tend to be okay. It's just they're going through the motions, yep, this week, next week, the cycle, yep, okay, this is where I'm up to. It's actually the spaces in between where people really struggle. And so I guess both as patients but also as carers, thinking about what is it about those spaces that make it harder for you guys, but also just for us as humans, right? This kind of black and white stuff we do really well. And so, you know, that old, I think it's a Chekhov quote about anyone can live through a crisis. It's the day-to-day that's actually really difficult. And I feel like for many patients I see, actually they're in the day-to-day all of the time with this kind of big nebulous uncertainty sitting on top of their heads. And so part of what I'm hoping you guys kind of leave today thinking about is, how does this stuff show up for me and what do I do about it when it does? I'm not going to pretend to have any magical solutions, by the way. I've stopped counting how many patients I've seen over the years, but no one's been able to come up with a, how do I get rid of the uncertainty feeling? So if someone in this room can, full props to you. I don't like your chances. So I just thought, I'm cognizant people may or may not know each other and may or may not feel comfortable talking about this stuff. But I just thought maybe if we just take a couple of minutes to kind of just get into the headspace of thinking about some of this. So my two questions are, how do you know that you're managing well? And how would you know that you aren't? And I guess a really important part in that is what changes in between those spaces. Is it about how you show up? Is it about a situational thing? Is it about the things that you stop doing? So often when things aren't going well, we tend to stop doing all of the things that we know are helpful for us. So I just want you guys to kind of take a couple of minutes. If people want to yell out answers, awesome. My guess is if one person's thinking it, everyone else in the room will be thinking a version of it. If no one wants to say anything, that's totally fine too. Cool.
I was going to say, when I was going through my treatment, I always felt like I was managing it pretty well. And then, you know, it's in the years afterwards where I think back where I realise how emotionally fragile it actually made me. So I don't know that I was necessarily managing it that well.
Yep.
At the time.
Yeah, totally. It's a tricky thing, isn't it? Because we often do what we need to do to survive. And I don't mean that in a kind of living outcome-based measure. I mean that in terms of what do we just need to do to get through really difficult stuff. And you're right, it's often in that time afterwards that people reflect and go, oh wow, like how did I do that thing? And depending on how you frame that, and for some people in the room, the way that you look back on that might to be, oh my God, I didn't do that very well at all. I should have done this better. I could have done these things differently. And for other people in the room, they'll look back on that and go, oh my God, how, like, you did the best you could in that space. And so it's a really tricky kind of thing. But I think, you know, current us always has ideas about what past us should have done. And unfortunately, most of the time, current us is kind of beating past us up and future us up often in advance. But yeah, it's a really challenging kind of thing to show up. Yeah, sure. Wow, this is a polite crowd.
Look, I found through treatment I was okay. It was just after COVID and things were starting to relax, and then I had treatment. Then what happened was I was over it and I was a lot better, but I wouldn't go out. So I found I really struggled to reconnect with my friends and my social networks, and because I'm retired, and I found it really hard to get motivated to go and see people and do stuff that I would be doing, and it was almost like I was scared, and my husband had to push me out the door to go and do stuff, which I'm sure you experienced the same. Thank you.
Absolutely. And I don't want to push or inquire too far, but did you feel better for doing those things?
Oh, absolutely. This was another 6 months. 6 months I've been going out.
Yep.
And it's taken a while to re-establish friendships because, with COVID and the treatment, I lost the contact and people moved. But yes, I feel a whole lot better, and I'm much more confident in myself now.
Yeah, awesome. The reason I asked that is I think most people in the room can identify that feeling of the idea of starting back up or going back to something is really, really overwhelming and really full on. Pretty universally, people will always tell me it's worth it. You know, it's very, very rare that I have someone say to me, oh, I went out and caught up with my friends and it was the worst thing I've ever done in my life. You know, much more often people go, actually, it was hard, but I felt good for doing it. And I want to keep doing those things. We will talk a little bit about this as we go forward, but one of the things that I will often kind of see in people is that coming out of treatment is a big deal, right? Even if you're feeling physically pretty good, you know, compared to chemo or whatever treatment you've been on, stopping that feels awesome. But people often don't allow themselves the space to go, you know what, I'm probably not back where I was. And so often in those getting back into things, starting with really small things is actually the way forward rather than trying to go back to exactly what you were doing before. And you know what? The worst thing that happens is you go, oh, that was really easy. Cool, awesome, do something harder. But it's much better to do that than go the other way, get completely overwhelmed and then not want to leave the house again for another 6 months because it was too hard. So baby steps. We might take one more comment if someone... Will you...
Is the mic?
Oh, yeah. Yep.
I'm here really in a carer role, but I did have non-Hodgkin's lymphoma myself 30 years ago. So I can, and I was stage 4, so I can say that it does take a long time for the what-ifs to go away. But then you start noticing one day that you don't have that thought, and then there are more days when you don't have it, and eventually you stop thinking about it. But it does take a little time. You have to be very patient and kind with yourself.
Absolutely. I think the that message of kindness to yourself is probably the thing that's going to resonate through all of our discussions today, both in our talks, but I guess with each other as well, because we're often much better at being kind to other people than what we are to ourselves. But absolutely, and I can imagine for everyone in the room, that's actually a really reassuring thing to hear, because I think when we're in something, it's almost impossible to see that there's any other side to it, and we're just going to be in this space forever. But for those people in the room who have been kind of sitting in this world for a while, things do change. They do, you know, the way we cope with them changes over time. So the last couple of years, there's been a lot of talk about resiliency, and it's kind of like in psychology land become a little bit of a dirty word because it was everywhere for a period of time. But I think it can sometimes be a really helpful, I guess, framing around what's our measure of success when we're thinking about how our headspace is in this. Often people will come and see me and they'll say things like, I should just be coping better. And when I say to them, well, what would that look like? They're like, I don't know. But there's this kind of inherent pressure that we carry around, I need to be doing well at this and I need to be coping well. The tricky thing is that actually coping well with this is sometimes struggling with it. Because if you look at the kind of counterfactual, if you imagine a world where somebody said to you, okay, cool, you've got lymphoma, and you go, no worries, I wasn't doing anything today. That would be really weird, right? But we don't ever think about that. We only ever think about I should be doing this better. I need to be coping better. When anxiety and worries and other stuff turn up, we kind of get a bit panicked and overwhelmed by them. And so I guess in thinking about this, I guess thinking about your own kind of measures of success in how do I know that I'm doing okay? And maybe the doing okay is actually, you know what, anxiety has showed up, but I'm okay with it. I don't need to fix it or change it. It's just okay to be anxious. You know, particularly around, you know, and I'm going to give a really concrete example of scan anxiety because that's something that comes up for most people most of the time. in lots of ways, from a psychology perspective, that's awesome anxiety, right? That is the most predictable anxiety that exists. We know exactly what it's for. We know exactly why it's going to show up. But I consistently have people coming to see me going, I need to get rid of it. It's like, actually, if we can make friends with that thing, it's not that it goes away or that it changes, but you have to put way less energy into fighting against it and trying not to let it like kind of show up. And so lots of what we're going to talk about today is actually, how do I kind of make friends with these tricky emotions and stuff that show up? And for some people, they will have never shown up before. And for other people, they might be a bit more familiar and, that's that anxiety that shows up all of the time. I know about that one. This idea of coping is not about not responding or not about being okay, or the Hollywood movie version of this where, you know, everything goes wrong and people are like, I'm totally fine. It's much more about, you know what, I'm going to respond appropriately to whatever's in my world. And in doing that, I'll kind of cope and adjust as I go through. So we kind of briefly talked about this a little bit, but it's really helpful to recognise when are you not feeling okay. I actually don't have my picture of a wave in here. I normally have a picture of a wave, where it's like a bit of an old school surfer, lost, you know, misspent youth really. I can't let it go. But one of the things on the wave is, for any of you guys who've spent time in the ocean, different parts of the wave equal different things, right? The start, flat part of the wave is totally safe and okay. The top part of the wave is where we kind of get into trouble. And in my case, ended up with 15 stitches across the back of my head, but that's a story for a different day. And so this emotional stuff is kind of the same. It's about where am I on the wave and where am I kind of sitting. So if you can catch stuff towards the bottom of that wave and go, oh, starting to notice that things are feeling a bit harder, or I'm not feeling quite as okay, it's much easier to do those things that help then, rather than wait until you're at the top of the wave and everything's feeling like a crisis and your capacity's kind of shot and you're really overwhelmed. Sometimes we can't avoid the overwhelm, and the worst thing that happens in that space is we tip over the front of the wave, things are really tricky for a bit, and then they'll settle down. And we're often really fearful about, well, what happens if that happens? It's like, well, if that happens, it's fine. We can manage that. That happens to people all day, every day. Do we want that to happen? Absolutely not. If we can prevent that, that's what we do, right? And there's absolutely, so in the service that I work in, primarily with young people, we actually proactively say, you know what, I'm going to see all the patients at the beginning, because we know at some point the wheels are going to fall off reliably. And what we found that actually engaging that stuff early on doesn't necessarily stop the wheels falling off, but it definitely means they fall off in a less dramatic way. And so that's a model that, you know, and particularly I would encourage anyone who knows that anxiety is kind of a bit of a presence in your world. You might have struggled with lots of change or uncertainty in the past. It's really worth going, okay, there's a better than nothing chance that I might struggle through this. Cool, I'm going to link up with support. And we'll talk in a sec about what that support might look like. But the other thing is, when people are showing up to clinic, particularly really busy clinics, it can be really hard to know whether people are struggling or not. Because particularly if I'm thinking about, you know, someone who might come into a clinic, medically everything looks okay, you might be completely falling apart inside, but no one's going to know that, right, unless you tell them. And so part of this kind of piece around how do I know that I'm struggling is, how do I then recognise that but also communicate about it, either to my people or to the hospital people, and how do I get support linked in? I always joke that it wouldn't be a psychology talk if we didn't put Maslow into the picture. That guy is totally, you know, he's absolutely made his money out of psychology land. But we sometimes forget the really simple stuff. And in the face of, particularly in treatment, but I think also in the periods after treatment, this idea of I'm going to be like totally nailing life and everything's completely under control and I'm like, you know, I don't know, some superstar at this. It's, you know, if you can manage it, awesome. But for most people, that's not actually attainable. But actually, there's a bunch of stuff here that we can manage. And this is the stuff around, okay, you know what? The drugs have completely screwed up my sleep. Cool, all right, well, I'm going to be really kind to myself, but I'm also going to work really actively on how do I kind of get my sleep as good as I can. How do I make sure that I'm kind of getting food in when I can? managing that social stuff, having some structure, having things that make me feel good. And they're often things that can be done, particularly on treatment, can be stuff that doesn't require heaps of energy. There are, of course, things that require loads of energy in that space, but thinking about, okay, where I am now, what can I do with that? Because one of these antidotes to managing the uncertainty is about connecting with the small bits that you can do stuff with. So, what do we do with all of this? So Erica mentioned that I work from a space called acceptance and commitment therapy. Unless you're a therapist, you're probably not going to know what that means, and that's totally cool. Therapists think about weird stuff that no one else really needs to think about ever. But essentially kind of thinking about, we're not going to get rid of these feelings and emotions because they're showing up because it's actually really reasonable that you as a human under threat are having a response to that. And as I say to my patients, I'm often way more worried if they're turning up and not having a response to this stuff. And so there's some stuff that we can do with this. So we can work around this idea that, you know what, it's okay that tricky emotions show up in this. We don't have to fix them, we don't have to get rid of them, but how do we manage them when they do show up? You would be amazed at how much just actually being aware and clocking that this stuff is happening is actually really powerful and really helpful, as is giving it a name. The number of people who come into me kind of feeling like they're going completely mad, and then when we might have a conversation, it's like, oh, this sounds like anxiety. They're like, oh, okay, cool. Well, I know you can do stuff about that. And so often this stuff that happens in our brains is actually, you know, our brain's job is to make everything bigger than what it needs to be, right? And our brain often tells us stuff that isn't true, but we don't question it because our brain's told us stuff. And particularly around anxiety, that's a really, really common thing that happens. And so kind of recognising things for what they are and naming them and showing up in that way is really helpful. There's also some stuff in here about how do we show up in the day-to-day, even when things are feeling really hard? What do we do with that? So now you get some, you know, nice comic, kind of, well, maybe not comic, but some cartoony type vibe, which makes me feel young and exciting. So when I'm talking about acceptance, I'm absolutely not talking about the thing itself. So there is not, you know, I'm happy for someone to prove me wrong, but my guess is there's not a person in this room who's like, lymphoma, awesome, great, best thing that's ever happened. You might have some thoughts about, oh, that's changed my perspective, and that was, you know, in time you might look back on it and go, that was actually a really formative kind of thing that happened in my life, and I'm now thinking about things that, but you could probably take or leave the actual process, right? No one's loving that bit. And so when we're talking about acceptance, people often assume that it's like, well, I just need to be okay with it. And it's like, if you can be, great. But most people I meet aren't in that space. And it's a really, really hard thing to reconcile. So that's not what we're talking about. What we are talking about, though, is how do you accept the stuff that comes along with it? Which is the fear, the anxiety, the worry, the sometimes, you know, sense of relief or, you know, other kind of positive things that we don't tend to think about. You know, lots of patients I see have been struggling with stuff for a long time. And then someone says to them, oh, this is lymphoma. And they go, oh, so I'm not going mad. There's actually something wrong with me. I've got a measurable, tangible thing. And so, you know, but all of those things that show up, there's kind of the thing, and then there's the thinking about the thing. And then invariably we get anxious about thinking about the thing. And then we get anxious about, you know, and so there's all of these layers. We can't do much about whether the lymphoma shows up or not. But we can do some stuff about what happens around our headspace around this stuff. People are nodding, so I'm assuming that makes sense. Yep. Okay, cool. I always, like I said before, as a therapist, I think about the way that people think way more than like regular people think about the way that they think. So I often just like to make sure it's like, am I actually speaking like normal, reasonable, kind of make sense vibe? So what do we do with this acceptance piece? People will often say to me, yeah, that's great, I accept it, now what? The process of accepting those emotions is about not fighting against them. And I've got a picture to come along with that in a sec. But how do we accept things? We kind of like our little dinosaurs of like, okay, I see you. I see that you're there. Ah, anxiety. I've been expecting you. You know, I think about, I'll use a scan anxiety example. It's like, okay, a week before the scan, you bet that thing's going to show up, right? It's like, anxiety, I've been expecting you. Here you go. You're going to come along with me for the next week. Okay, cool. What do we do with that? Okay, well, I'm not going to fight with you because that's not helpful. Well, I guess you're just going to be there and you're going to be with me and be present. Now, this is really easy to say when you're not feeling really anxious. Being anxious is uncomfortable, right? And so part of this acceptance stuff is, how do I allow that space for me to kind of be open to whatever shows up? So if that anxiety shows up and it's uncomfortable, that too is okay. And I can sit with that. And and that takes some practice, right? For anyone who's having their first scan versus their 20th scan, you'll know what I'm talking about. Over time, this stuff does kind of shift and move, and you get better at recognizing that, okay, I can sit with this, it's okay. But that kind of, and I'm very happy for you to keep the pictures of dinosaurs in your head. By the way, most of the time when I'm talking to people, they have an anxious version of themselves that kind of shows up on their shoulder. You can make it look, do whatever. The idea of it showing up is actually a really helpful thing because it helps us externalize stuff. Because when stuff's happening in our brains, it's hard for us to make sense of it. Whereas if you think about a little dude coming and showing up on your shoulder, that actually, it kind of gives us a bit more space from it. Oops. So do you guys remember doing tug of war as a kid? Yeah. I don't think it's something that adults do. I feel like it's really a child-based activity. I mean, I haven't done it as an adult. Maybe other people do. But you know, when you're in a tug of war, our assumption is that you have to you have to keep fighting with that thing, right? The thing that we never think about, and I wish I'd clocked this when I was a kid, is that if you let go of the rope, the other team just falls on their bums. We can do this same kind of thing around what happens in our head. The more we fight with it, the more we try and get rid of it, the more we if we assume that part of lymphoma is that anxiety or other stuff will show up, us fighting against that doesn't do anything. It's just like, hitting your head up against a brick wall. The wall doesn't move, you just get a sore head. And so if we apply that same logic, it's like, okay, cool. Well, if this is part of how this stuff shows up, then I'm not going to fight against it because what's the point? But what I can do is go, okay, I see you. I know that you're there and it's okay. You can just be here with me. And even though sometimes that shows up and I feel really uncomfortable, it's okay. The biggest antidote, I can never say that word properly. I should probably find another word, to be honest, to uncertainty is the present. Because all of uncertainty is future-based. And so when I'm talking about coming back to the present, I'm not talking about doing hectic mindfulness of 20 minutes where you're sitting in the mountain in the cold and not registering that or whatever people do. I'm not talking about silent retreats, although if you can do that, full props to you. You might be shocked to know that that's not my vibe. Shocking. People tell me it'd be really good for me. But I'm talking about really, really simple stuff. So this is stuff you can do on treatment, you can do it off treatment, you could do it while you're on the bus. These are little tiny things of how do I just get kind of a second of circuit breaker to bring me back to the present? The ones that I tend to find work really well for people is sound-based ones. So, what's 5 things I can hear? It's I can hear someone, tipping water into their glass. There's probably someone out in the corridor making some noise about something. The first couple will be really easy. Then you've got to really focus. I don't recommend doing this at night, by the way, because you'll freak yourself out if you're in the house by yourself. One of my adolescent patients found that would have been a helpful warning. But, these things that kind of just bring us back to the here and now. The other a good one that works really well for people at night often is really simple stuff like laying in bed and telling yourself that you can't move. And you will have every itch, scratch, discomfort show up in your body in about 3.5 seconds. And it's just noticing that and just not moving and just staying really still. Or if that feels a bit hard, really simple stuff like rubbing your feet together under the covers and just really noticing what that feels like. And I'm talking about 10, 20, 30 seconds. I mean, you can do it as long as you want, it doesn't matter. But it's just stuff that kind of helps bring you back to present. So when you go, anxiety, you've taken me into the future, again, we'll use the scan anxiety because it's a really nice example. It's like, oh, you're telling me the 400,000 ways that this is going to go wrong when I go to see my doctor tomorrow, and they're going to give me X, Y, and Z news, and everything's terrible. And going, okay, cool, I see that. I'm just going to come back to the here and now. What can I hear right now? If you like music, listening to things like your favourite piece of music and like pulling out the drum beat or the violin or whatever it might be can often be really helpful as well. Like I said before, there's a really big benefit in naming stuff. Whether that's anxiety, whether it's grief, whether it's sadness, whether it is relief. You know, thinking about what is this thing that's showing up for me and why is it showing up? And part of the things that we do when I'm having conversations with people is people like me are often the person who can put language to this stuff for people, because things will be swirling around in their minds and they won't quite know what that thing is. But sometimes you can get to that stuff by kind of thinking about, okay, what am I feeling? Okay, now why do I think I'm feeling that? Okay, so what do I think's underneath that? And invariably the stuff that will be underneath it, and you know, there's a million options, but in this space it's often things around grief and sadness, anxiety, worry, panic. Usually if we dig down far enough, there'll be some stuff in there about death and worrying about death. And that's not a you guys thing, that is a I bumped into a really scary thing in my life thing. And so sometimes just recognising that stuff is actually really, really powerful. I've got a patient of mine who will show up and, you know, how's your week been? Good, yeah, that death stuff's showing up all the time this week. But it kind of just takes the pressure off that, right? It's like, oh, I can see it. I don't need to do anything with it, but I just know that it's there. So, my guess is that all of you in this room want to live value-filled, nice, lovely lives, right? The cancer stuff, the treatment stuff, the process of being unwell often gets in the way of this. And so one of the things that I think is most important in this space, no pun intended, is to actually work out what's important to me. How do I show up for those things? And my guess is that at the time that you were diagnosed, you worked that out really, really quickly. It would have been uber obvious what's the stuff that actually is the most important thing. People will often joke with me, they're like, yeah, the second my doctor told me, I was just like, oh, I don't need to worry about work right now, or I don't need to do whatever. And I think sometimes when we're on treatment, that can be really easy to navigate because you've got limited capacity and the things that need to be done are the things that need to be done. And often the people who you want to turn up are the ones who are showing up, and there's some complexity around that, which is a topic for another day. But when you're kind of entering in that post-treatment phase, this is a time where this stuff gets really tricky. So it might be that you're thinking about the world in a really different way to what your people are, and that can sometimes be a tricky thing to navigate. I see that quite a lot in my younger patients who have kind of bumped into this really full-on stuff, and then the other people in their world haven't clocked this at all. But it might also be that you want to put your energy into something that you hadn't necessarily thought about before, and then having to navigate through that and work out what to do with it. And so it can be really helpful to kind of reflect back on, okay, when this stuff happened to me, what was the stuff that I wanted to prioritise? How will I know that I'm living a good life every day? And that, like, I'm rarely talking about really big stuff. This is the, you know what, I'm going to sit out the back with a cup of tea in the sunshine watching the magpie on the fence. It might be the, oh, you know, I really just love catching up with that friend for a coffee every week or every couple of weeks. You know, it's thinking about those simple things. It's rarely I'm using the trip to Disneyland example. I mean, most of us, I can't imagine, could think of anything worse. But, you know, it's that idea, like, I think people often put lots of pressure on themselves to be like, I have to do this crazy big thing for stuff to be meaningful. It's like, that stuff is rarely meaningful. It's the much smaller stuff that's actually much easier to manage. And as we were chatting about before, there's a piece in here about being kind to ourselves. Like I was saying, we are much better at being kind to our friends than what we are to ourselves. And I heard this really beautiful quote a while ago where they were saying, you would never talk to your friend the way that we talk to ourselves. Sometimes there's a real power in actually just going, you know what, dude, you're doing the best you can, and it's okay. It doesn't need to be perfect. It doesn't need to be brilliant. It's just, we're just getting through this. And I think thinking about your example of before, of when you're looking back on how you cope during treatment, or even in this survivorship space or wherever it might be, being able to say to yourself, you know what, I'm showing up the best way I can right now. And maybe in the future you'll look back and go, oh, I should have done this. It's like, no, in the moment you're just doing what you can. It's really lovely to just remind ourselves of that sometimes, regardless of what else is going on, lymphoma-wise or otherwise, being able to say, you know what, and this is something particular, I think, for carers, and I mean this in the kindest possible way. Carers are often really terrible at doing this, right? As humans, we're not very good at it, but carers are often, in my experience at least, you know, kind of beating themselves up for not being able to be everything to everyone, or not being able to nail everything, or it's like actually in that space, it's really important to go, you know what, I'm doing the best I can. Oops. I don't know whether anyone's read Phosphorescence, but there's some of these like beautiful little snapshots of like just capturing little moments of life. And I think if you don't take much else out of this conversation, it's about thinking about what can I do in the moment that connects me, helps me feel better, even if it's just little, you know, seconds of pleasure. It might not be lots, and particularly if people are on treatment, this stuff can be tricky. But it might be that, oh, I really love that TV show and it's on tonight. I'm really going to allow myself the pleasure to watch it. Or, you know what? I'm not really feeling like much to eat, but there's this thing I'm really craving. How do I sort that out? But, you know, in this survivorship space, this is absolutely a time to allow yourself space to go, okay, how do I connect with what's important to me? How do I just be in the here and now? So, how can you check in with yourself? I am very close to finishing. I have this is going to be shocking to everyone involved. I have a habit of over-talking. And so I was like, I promise Erica I'm not going to run late today. There are some really lovely things that you can check in with yourself around. What can I do to help myself get back on track? These are usually simple things. If I've stopped going and seeing all of my friends, how do I connect with my friends again? You know, if I've been in bed for a week, and I've probably been in bed for a week because I feel terrible, but my guess is you'll feel better if you get out of your jammies and go onto the couch. You know, it's often these really, really little things. I can't control the uncertainty, but there are a million things that are in your control. Those decisions about how do I show up, you know, what do I do with my day? And if a day's too big, what do I do with the next hour? You know, they're the things that we can kind of hold on to. Is there something I can do that will make things easier, better, more manageable? We're often kind of our own worst enemies in terms of making things more complex, more difficult. And, you know, that's not a lymphoma thing, that's a life thing. I had a conversation with a colleague just this morning where I'm like, you could just not do that. And she's like, oh my God, I never thought of that. You know, we do this stuff all the time. Who can help me? And how do I shift through this space? And maybe that shifting through isn't a right now problem, but it's like, okay, what can I kind of line up to make this as tolerable as it can be? So how do you get support? Like I said, working out that there's a problem or something that you want support with is the first step. I do this exercise, this will sound a bit weird, but I do this exercise with new grad nurses when they start, and it's a really, really helpful thing to do, where you get people to trace the outline of their hand. You know what that means, I don't need to demonstrate that, but you know. And then in each finger, writing down the name of someone who you can turn to. And that could be, you know, friends, family, doctor, psychologist, but it could also be the dog, you know, like who are the things that make you kind of feel better? Who do you connect with? Don't underestimate how helpful your medical team or other teams can be. One of the big benefits, and I suspect Judith will chat about this a little bit, one of the benefits of sitting in big multidisciplinary teams is that we get really good at recognising how do we support people. And so it's not unusual that I get kind of phone calls from doctors saying, hey, I've just got someone in my office, they're not quite as they are normally. Do you mind touching base with them? You know, those kind of things. So the team can be a really rich resource for help. Your GP, if there's someone that you kind of see and trust. And recognising when it's helpful to talk about stuff versus when it's not. You know, Most of the time in relationships, one person will be a talker, the other person won't be. That's usually how it works out. If you've got two people who are non-talkers, not much happens, and two people who are talkers, too much happens. And so recognising, is there stuff that's kind of happening in those communication patterns that might be making things more difficult or easy? And that's a kind of more tricky one to work with, but it's good to be aware of. And I just wanted to finish up with this idea of everything's just for now. And we can look at that in a really existential sense. But I think particularly when we're talking about kind of periods of illness or other things, is that when we're in them, it can feel like it will never end and that there's never any return to anything. But actually, even in really dark times, there is always stuff that kind of helps us get through. We as humans are hardwired to push through the most horrendous periods of whatever, right? That's why we're still all here. And so allowing yourself the space and time and capacity to say, however I need to get through this, if it's perfect or not, my guess is it won't be perfect, by the way, that's okay. I can just kind of get through it and work through. I think that's it. So I think, were we going to do questions at the end?
Yes.
Sweet. Awesome.
My kids recently did that exercise where they traced around their hand, and it was actually really beautiful, the little names that they'd written in the fingers as well too. So I recommend doing that for anyone who, it's cute what you find out with your kids as well too. Thank you, Tony. I think, show of hands, did that really resonate with a lot of people in the group as well too? Yeah, I think even as I was listening to it, it's really, really good to then go back as well too. And as a healthcare professional, I see it so often that there's this huge focus on getting you through the treatment, one step in front of the other. You have all this contact with the hospital servers, with the nurses, with the doctors, you're constantly in and out, just like Tony said, and then it stops and you've got nothing. So it's a challenge, and we recognise that as well too. So thank you very much, Tony. So we will hold questions over to the panel discussion as well too. So our next speaker is Dr. Judith Trotman, and she's going to be talking about clinical trials. Very timely, considering where we are. So Dr. Judith Trotman is the head of haematology at Concord Hospital here in Sydney. Dr. Trotman is committed to embedding lymphoma research into world-class clinical care as the founding director of the Concord Hospital Haematology Clinical Research Unit. Her research is characterised by a commitment to focusing on current priorities of lymphoma patients, and she is also the current chair of the ALLG. Welcome, Judith.
Thanks, Erica, and thanks, Tony. I'm going to channel my anxiety that I always have before ever giving a talk, and I'm going to let it come in and use it. Okay. But until then, here's the lecture about clinical trials. And if it's all too easy for you, you can go like this and make me roll it along faster. And if it's too complex, just drift out and come back in when it gets a bit more simple, perhaps. Okay, so I hope that as an outcome of this session, you will, I'd rather do this way because then I can actually see you. You will have an increased confidence and trust in our trials, in particular our trials, and an understanding of how our trials differ from industry trials or other clinical trials. You'll understand the why for clinical trials in terms of new treatments, new treatment pathways for patients with blood cancer, and also for improving the evidence for blood cancer care changes. I am going to have to look at this. I'm just going to rearrange myself a little bit so I can actually see you as well as see the slides. So, what is a trial? It is a carefully designed, a carefully constructed study conducted in humans under the code of GCP, and I'll come back to that because that's a very important code, that seeks to determine under controlled conditions, firstly the safety and then the effectiveness of a new treatment. So it's the crucial link between the research lab and the patient. And we all admire those photos of the scientists in their white coat with their test tubes, all right? They're working, you know, we all donate money towards research at all these medical research institutes, all right? I say that scientist is working on trying to develop a cure, a possible cure for tomorrow's patient. Our clinical trials are designed to deliver that cure to today's. And the code of good clinical practice is absolutely central to what we do to make sure our trials are ethical and robust and can reliably answer the question that they set out to ask. And it's an international standard developed from the Declaration of Helsinki that sort of came out of the Nuremberg War Crimes Tribunals. And, you know, I'm sure someone could do a whole 1-hour lecture on the history of the evolution of this code of good clinical practice. But it is an international standard to which we all adhere to. That ensures that the humans who participate in clinical trials, whether they be healthy volunteers or whether they be patients, have their rights and their safety and their well-being placed above all other considerations in clinical research. So it's not just unnecessary bureaucracy. It's really, really important, central to what we do in clinical trials. So why do we have them? Obviously to improve treatments for patients, but also to advance the medical knowledge. To provide, you know, access to treatments for patients, but also to advance knowledge to change future patients' outcomes. And this is a wonderful testimony from Hemi, a Maori New Zealander who's a Hodgkin lymphoma survivor and clinical trials participant in a trial that has really established a new standard of care for Hodgkin lymphoma. Any of you in the room who may have had escalated bear cop, that's a pretty blunderbuss, pretty ruthless, highly effective cure for Hodgkin lymphoma. But the clinical trial, the randomised phase 3 clinical trial that compared escalated bear cop with BRECAD showed that not only was BRECAD a little bit better, but adding a targeted therapy to and dialing down the chemotherapy was so much better tolerated for these patients. So it was a win-win all the way for patients who ended up on BRECAD. And you might think, well, what about the poor sods who got escalated bear cop? Well, they got escalated bear cop in the context of a very carefully monitored, rigorously run clinical trial under the code of good clinical practice. They just weren't given escalated bear cop without their own study concierge, their study research nurse, helping them navigate the pathway and making sure all the dose modifications were absolutely spot on for them. And that is one of the reasons why patients, even when they're receiving the standard of care treatment in a clinical trial, often do better in that clinical trial. So, how do trials work? I hope the one thing you get when you go home from today is you realise that in clinical trials under the code of GCP, it's safety first. I know you're all looking for the next U-Butte drug, right? But safety has to come first, has to underpin the protocol before we start thinking about effectiveness. Now, we think about our laboratory studies in cell lines, in animals, and then we move into our phase 1 trials where we start doing pharmacokinetic and pharmacodynamic testing in terms of dealing with how well the treatment, usually I'm talking here about a drug trial, how well the drug, which is either swallowed or injected, how the blood levels go, how the safety is, what we call the pharmacodynamics, the way the patient responds to that drug and tolerates that drug in ever so smally incrementing doses. So safety first. And that's done, phase 1 trial might be like one of my sons who goes to a healthy volunteer trial, signing up for remuneration while he's at university, and he might be studying a new cholesterol drug or hypertension drug. in cancer care, phase 1 trials are generally for patients who have exhausted all standard and available treatment options, but still remain well enough and motivated enough to try something that may or may not help them, but will certainly inform medical research and the development of drugs, drug development further on. Because all the drugs we give you in treating your lymphoma or other cancer, if there's anyone who's not got lymphoma in the room, have all been developed through clinical trials. And then we go on to the phase 2 studies, which again, safety is first, but we're starting to gather in a larger cohort of patients data about how efficacious that drug is in that rather narrow cohort of patients who tend to be motivated, healthy, driven patients like yourselves who have not good renal function, not overweight. You know, we've got to be a bit careful that the trials population sometimes doesn't always match, or often doesn't always match the real population. But we certainly try very hard in our ALLG trials to be truly inclusive in the patients that we enrol. And a phase 2 trial will give you some data about how not just how safe and how tolerable the drug is, but is it starting to work? Is it actually showing evidence of value? And then it's the large, what we call randomized controlled trial, the phase 3 trial, that compares that new treatment that has been shown in phase 2 to be efficacious with the standard of care. Now, the number one question that patients participating in clinical trials is, I don't want to be randomized for a placebo when I need treatment for my cancer. That would clearly be a highly unethical trial to conduct and would never get approved by an ethics committee. The only time a placebo is used in a clinical trial is when standard of care is observation. And so one ordinarily wouldn't be doing something. So, for example, after you've achieved remission for your lymphoma, the natural approach for most patients is to undergo observation and no further therapy. But the ALLG has conducted a number of trials where we've added on a maintenance therapy designed to demonstrate whether we can improve remission duration while at the same time keeping patients well and healthy after they've completed their induction, their first-line chemotherapy. And the standard of care that's appropriate in that situation is observation, no further treatment. How do trials work? Well, we follow the rules. We follow the protocol. But we don't slavishly follow the protocol. And sometimes we have to deviate from the protocol in the interests of patient safety. The protocol has to be clearly written out so that it can be safe and can be reliable. It is unethical and ethics committees will not allow us to run trials that are not designed to be statistically robust and to answer the question they set out to answer. They must go through a series of highly regulated processes before conversation can start. The ethics committee will review all the documents, the protocol, the various study manuals, the patient information sheet and consent form, and then a governance office will review all the risks. When I'm conducting a trial at Concord Hospital, have I got all the resources, all the qualified personnel who are able to safely conduct this trial in this patient population? The clinical team is a very large team. It's not just the doctor or what we call the investigator, your treating hematologist, but there will be clinical trials nurses, clinical trials data managers, study coordinators and scientists, and unseen by those of you who participate in trials at our hospital is this whole, organisation of 30 staff, isn't it, Delane, at the ALLG, who are coordinating the trial and making sure that indeed, as study sponsor, as the responsible authority running the trial, and making sure we are following the protocol to the letter and reporting all the important outcomes that are occurring during the conduct of that trial. So at the beginning of the trial, the team will assess your eligibility based on your medical history. All right, you've already been pre-screened and determined that it's probable you're eligible to participate in a trial before you get approached. Never 100%. We always get it wrong sometimes when we discover someone's got active hepatitis B and is not eligible, or their liver function is too abnormal. But generally you will be pre-screened, because there's nothing worse than talking to a patient about a trial that makes them really excited and then go, oh, actually you can't be enrolled. And then we start the screening and informed consent process. And I very, very firmly believe we should be screening everyone to just recruit a few. And the informed consent process is so important, and it's an iterative process. I don't know, put your hands up. Have any of you participated in a clinical trial? You're allowed to put your hand up because you participated in your own clinical trial down there, Andrew, your own research project. So that's great. There's so many of you. Clearly we've got a very motivated and very informed population. That informed consent process is not you taking home the 38-page informed consent document. All right? It doesn't stop there. It doesn't even start there. I think that's the worst thing to get a patient to be willing to participate in a trial, is to have the study coordinator email them the consent document. Now, I need to talk to them about the concept of clinical trial. I need to socialise the whole concept with them before we start ramming a whole lot of information down and overwhelm them. You've got to choose your right moments to gradually and iteratively explain the clinical trial process to the patient. And once you've signed that consent form, that consent is an ongoing process that constantly needs to be reviewed, because that consent can be pulled out at any time. During the trial, the patient's monitored carefully by the trial team, and there will obviously be dose modifications. The dose that you start on is not necessarily the dose you'll finish with. And if it's either, and this is really important for patients to get that assurance, that if ever it is appropriate for the patient to stop the treatment and or go off the clinical trial, we will tell them. Because the clinical trial is simply a means by which we are proposing the best treatment available for them. And if it is no longer the best treatment for them, we have a duty of care to let the patient know. As the trial ends, we gather all the data together, send it off to the statistician. There might be a bit of what we call data cleaning and further queries that get sent out to the trial site and the patient. We report the results at scientific meetings, and then we publish them in medical journals. And the ALLG has conducted over 160 trials in the 5 decades of our existence, and published at least 220 odd publications. At the moment, just to give you a concept of how big the ALLG is, we have 1,200 investigators, nurses, data managers as members of the ALLG. So, there's this whole body of people all around Australia and New Zealand who've got your back, okay? So, I said informed consent is an iterative process, because it very much is. And I train my registrars, because I have to remember this structured way when I actually sit down, having socialised the concept of clinical trial participation with the patient, and I sit down and go through that central part of the informed consent process, which can take an hour sometimes. I try not to let it go beyond that, even though some patients keep coming at me with the questions, because we're just all saturated, and there's very little you can remember after more than half an hour, I think. But I always remember my PPRV, AVC. All right, talk to them about the purpose, why this trial is being conducted. explain to them, walk them through the protocol, the treatment plan, the various procedures that may be involved, the duration of the trial, the duration of the active therapy. Talk to them about the risks. There are always risks of participating in a clinical trial. There are always risks to treatment for blood cancer, and we have to go through and unpack what are the general risks of the treatment, and then what are the additional risks that exist when you're participating in the clinical trial. And along with that, the additional burden, the additional blood tests, the more meticulous and rigorous imaging, repeated CT or PET scanning monitoring that you may get. And we talk about the potential benefits. All right, it's very, very important we don't oversell the potential benefits of clinical trial participation, and also to talk to them about the alternative treatment option to participating in the clinical trial, because it's very important to help the patient weigh up the pros and cons of their different therapeutic pathways. And reiterate that informed consent is voluntary at all times, is confidential, and give the patient the assurance that just because they sign up to the clinical trial, again, I'm sounding like I'm banging on about this a bit, but it's just so important that the patient realise that if it is perceived that it is no longer in their best interests to continue on the trial, that I will be telling them that. And the other important part of informed consent is that the patient must have capacity to document that consent, make and document that consent. So you tell me, put your hands up if you've got some other ideas. Why do patients consent to participate? Sometimes it's very obvious, and that there's an early access to very promising therapies that may be already being utilised overseas that are not yet PBS funded here in Australia, or really changing, a real paradigm shift in terms of, and we've had so many of them in this revolution of lymphoma care in the last 20 years, that, you know, really changed the way that we target the biologic drivers of the lymphoma and move us away from the blunderbuss chemotherapy of the past. Participating in the clinical trial even when the treatment is standard, because as I say, you get that clinical trial concierge, someone who helps you navigate that journey and understands and informs you about the various parts along the way as you become more and more medical literate during your treatment journey. A lot of people do it to benefit to medicine and science. I have a lot of patients going on a clinical trial called Rationalise now, who are willing to be randomised to stop their immunoglobulin replacement therapy, because we really, really need to know whether continued immunoglobulin replacement therapy is better than or not, compared to taking a daily antibiotic or having an antibiotic script on standby if you get an infection. They see that as being a really important benefit to the patients who come after them. And certainly clinical trial participation will speed up the development of effective therapies for future patients. But as I said, it's very, very important that we don't oversell potential superpower advantages from clinical trials participation. Why not participate? Because occasionally I get a few regular long-standing patients who I talk to about a trial, and I know, Judith, that's not for me. I said, yeah, but you're going to listen, because informed consent is important, but so is informed dissent, and I need you to understand what you're saying no to. It might not be the right question for you. It might not sit right. It might not be a priority for you, and that's fine. There is always risk, and that must be acknowledged and quantified where we can. But there are always unknown risks to any treatment, whether it's on a trial or not. And it's certainly a lot easier just to lay yourself there and say, just give me the standard of care. I just do not have the time and space to think about this clinical trial when I've just been diagnosed with this, life-threatening cancer. And it often is somewhat onerous for patients because there tend to be more clinical visits and more blood tests and imaging. So we've got 3 different clinical trial sponsors. The industry-sponsored clinical trials where they develop a new medication. It may have been obinutuzumab, the next generation rituximab. It may have been brentuximab, the antibody drug conjugate targeted against CD30 on the surface of the Hodgkin lymphoma cells. Might be any one of these novel enzyme inhibitors that literally just switch off the activity of chronic lymphocytic leukemia, mantle cell lymphoma, Waldenstrom's. You know, there are so many fantastic new targeted therapies that industry have brought out for lymphoma over recent years. There are the cooperative clinical trial groups, and the Australasian Leukemia and Lymphoma Group is just that. It's the cooperative group for all the clinician researchers, the haematologists across Australia and New Zealand who conduct clinical trials not just in leukemia and lymphoma but also another blood cancer called myeloma. You may have been sitting in the treatment therapy centre beside a patient with myeloma, with myelodysplastic syndrome and some other rarer blood cancers. And then there are the investigator-initiated trials that are led locally per hospital. Are they different? Well, there are just most of the time they're the same, but because they're all ethically approved, they're all scientifically valid, right? The ethics committees are very, very clear, have a very clear remit under the code of GCP, not just to make sure there is no harm, but make sure the research question is scientifically valid and appropriate. Safety is always prioritised. It's designed by those 3 different groups. Funding is often very different. Obviously, pharma trials are funded by pharma alone. The ALLG, certainly a lot of our funding for our clinical trials comes from pharmaceutical companies. But you can have no doubt at all that Delane Smith, our CEO there, is looking through the nitty-gritty of all the contracts very, very carefully, and we have full intellectual property rights and authority over how we design the question and what we do with the data, all right? It is us who are the sponsor of the trial. And we're trying to do a trial with their drug to utilise their drugs in the best ways that meet the priorities of our patients. And we certainly get a lot of funding from the National Health Medical Research Council. The Medicines Research Future Fund was a real game changer for us when that came available 10 years ago, and similar funding for investigator-initiated trials. Now, do I need to roll it along much faster? Is that my problem? Sorry. What are the primary motivation is right up top there, all right? They want to bring drug to market, and good on them. We want to refine treatments and improve treatments and get better treatments for our patients. I think I've spoken a little bit about the ALLG already. I forgot I had this coming, but all credit. We've actually had over 13,000 patients participate in 160 trials with over 1,000 members. And we want to do the trials that meet your priorities, and that's why I want to whip through these slides, because I want to hear about your priorities. And we're a not-for-profit organisation and registered charity. Here's the membership, and just for a little bit of a New South Wales flavour, what a big week we had this week, all right? We enrolled our 4,000th patient from New South Wales on clinical trials, so just in case that was one of you in the room, well done, thank you. And we do it all across the state at 46 sites, all right? It's not just at St Vincent's and North Shore and Concord, it's across New South Wales. And here are some of our leading New South Wales clinicians from Newcastle, Wollongong, the Central Coast and Orange. Lots of patients across all the different blood cancers, of whom 600 New South Wales patients contributed to our lymphoma trials over 50 years. 50 years, we're the oldest clinical trials group in Australia. is a patient of mine, Brian Mantell, who shared his story, but no time for you at the moment, Brian. Sources of information, the site trial team, obviously your treating doctor is number one person to ask about. The information and consent form, ClinTrial Refer, I'll show you a little bit about that later. The registrar, I've never known a single patient who goes to that register, but good luck to you trying to navigate and try and find a relevant trial for you. And clearly here, support networks like Lymphoma Australia. Lymphoma Australia do so much work to try and keep in our ears and make sure they know exactly what trials we've got around town. Here's your site team. We'll whip past that. Oh, just one, no, too risky to go back. The other important thing is that we'll try. Ninos, yes, great. See, Ninos is helping me now. It's very important that you appreciate that even before we approach you about a clinical trial, it's been discussed in our multidisciplinary team meeting, all right? We've got the new cancer centre at Concord Hospital and we've built a war room, all right, like Donald Rumsfeld had with the big circular, semicircular horseshoe, so that we can see all our colleagues' reactions as we're discussing our proposed treatment for an individual patient. So multidisciplinary team peer review of all the treatment approaches is so important, whether it's a clinical trial or not. The consent form, again, good luck to you understanding everything on the consent form, and as you read it, make sure you've got your red pen or your highlighter pen and make notes as you go through it. The clinical trials website, and I just highlight for any of you who are digital natives, ClinTrial Refer is free to download. Conflict of interest, I built it, but I don't make a penny out of it. And it's an app. If you were downloading the Haematology Australia New Zealand or the Haematology New South Wales app, it only shows the currently recruiting trials. The registry will show all trials, but this app only shows trials that are currently recruiting. And you can identify your particular lymphoma, like newly diagnosed follicular lymphoma, and you can identify, oh, hello, my own Betrayer study just happens to pop up. There we go. The ANZ CTR website, and as I said, Lymphoma Australia is a key patient support network, as well as the Leukemia Foundation have a lot of material there for patients with cancer, with lymphoma, as well as with leukemia, and likewise the Cancer Council. So, some key tips. Will my care change? What's the purpose of the trial? What's expected of my involvement, risks? So again, reiterating the messages that I gave about the informed consent process. Because it's very important that a clinical trial might not be the right thing for you at this time. Here's a lovely testimony again. Do go to the ALLG website. There's some wonderful, absolutely warming testimonies from various patients who've been on clinical trials, that's great to read. Now, this is what we want to talk about. This consumer representative panel. We've got these 4 talented, well-informed, articulate advocates for you. But we need more. We can't have 1,200 investigators and 4 patients, all right? No research about me without me. And we really would love like-minded people to consider participating in our consumer research panel, all right? Might only be for 6 months, doesn't have to be for 6 years. To provide even just providing some feedback. What do? They ensure our research methods are consumer friendly. All right, Judith, that patient is not going to come back for a blood test every week. All right, it's got to be monthly. Justify why it has to be weekly. That sort of thing. Looking at it from your perspective. Helping write information, fact sheets about trials, because I write fact sheets that are way too complicated, I'm sure. And I certainly can't do anything in Cantonese or Arabic. might give us some suggestion about how we can promote participation in trials. Our radar clinical trial, we're going to have one of our young patients, do a little bit of a TikTok, are you on our radar sort of promotion to young digital natives with Hodgkin lymphoma. Raise the consumer perspective on ethics and data privacy and consent, and just making the public aware about us. No one knows about the ALLG, and we'd like to be a bit more known, because I think our members do amazing work, and provide lay summaries and disseminate the research findings. And this might be a segue to a little video very soon. Do connect with us. You're a bit intimidated and you don't want to be on the consumer representative panel, that's absolutely fine. But subscribe, connect with social media, all right? Or get your younger children to connect with social media if they're the digital natives in your family. And help fundraise for the ALLG, knowing that every dollar you fundraise is going into a clinical trial that meets your priorities, not industry's priorities. So, are we now going to do a bit of a Q&A with you, Emma? Are you going to?
Sharing the story.
You're going to share a story. Fantastic. Come. We would love to hear about your story. And I understand you've come all the way up from Melbourne, and you're a very well-informed participant in the HD10 clinical trial, but we'll leave you to tell your own story. Thanks so much for coming up today.
Thanks for having me. And thanks for your speech, Judith. It really resonated with me on multiple levels, which we'll soon find out why. So good afternoon, everyone. Thank you so much for coming and for having me here today. My name's Emma, and 4 years ago I had advanced Hodgkin's lymphoma, and thanks to the HD10 trial that Judith mentioned before, run by ALLG, I'm complete metabolic remission and get to receive my cured stamp next year. Fingers crossed. To add an interesting point, I'm also a clinical research nurse. So when I took on my role 7 years ago, I had no idea how helpful it would be to me personally down the track, which I'll explain shortly. So a bit about my story. Prior to May 2019, I was a well, fit person who didn't smoke, didn't drink, didn't take any drugs, never had a major illness or surgery, and led a very active lifestyle. I even was competing in dance competitions a couple of weeks prior and wondered why it took me a little longer than usual to recover. My first B-cell symptoms, being fever and night sweats, presented on the 5th of May 2019. And after a very thorough GP assessment, some preliminary tests, and then admission at my own hospital for a plethora of more tests, 6 days later I was diagnosed with stage 4 Hodgkin's lymphoma. Commence head spinning, shock, disbelief, and confusion setting in, as I'm sure that resonates with a lot of people in the room right now. Now, during this time, I had met my haematology team and Associate Professor Matthew Koo, who became my long-term haematologist. From the first day I met Matt, he would come and see me daily, go through what we knew so far, educate me, and answered every single question I had, every single day. He would let me ponder and think things through, come back and answer my next lot of questions. I distinctly remember him saying to me on one of the days, "It's okay, we'll get you through this, Em." And you know what? I believed him. Not once did I have a negative prognosis comment from any of my treating team, and I feel like that made a really huge difference. After my diagnosis was confirmed, Matt came in with some papers in his hand and another member of the team that I hadn't met yet, insert clinical trial coordinator. He said to me, "Em, I've got a trial I'd like to talk to you about." And I say, well, now I realise this is really daunting for most patients and it's usually a lot of information overload. But for me, this is when my brain woke up. The fog cleared, I sat up straight and he had my full attention because thanks to my job, trials are what I understand because it's what I do every day. I've never been so thankful for my job to help me want to make the best decisions of my life. Matt went on to explain the purpose of the trial, possible outcomes, possible side effects, benefits, risks, and what they knew prior to the trial, which led to the trial. After he finished, I said to Matt, so what you're saying is that I have a 50% chance of receiving standard treatment and a 50% chance of receiving, receiving a variation of standard treatment that offers the same success rate but with less side effects? He said yes. My decision was a no-brainer. I said if I didn't do the trial, I was going to receive standard treatment anyway. But if I did do it, then yes, I might still get standard treatment, but I might also get the equally effective varied treatment with less side effects. Now that sounds good to me. To clarify, I did read through the consent form a fair few times, writing my questions all over it, like the highlighter like you and the red pen. And yet again, Matt would come back each day, answer all of them before I signed on to the trial. I'm pleased to report that I was fortunate to receive the varied treatment, which offered equal effectiveness and less side effects. And oh boy, they weren't wrong about that. From what I read, that what you could experience to what I did was definitely more mild. And that's not to sugarcoat what having chemotherapy is like, but I really feel like I walked through chemo compared to what I could have experienced. Yes, I lost my hair, but that was a good sign. Yes, I had chemo brain. I'd forget all sorts. I was tired, but I didn't need to sleep during the day. I was nauseous once and ate the whole way through, thanks steroids. I had mild tingling in my fingertips, which would go away after the second week, and I would get some thigh weakness, which just meant I couldn't walk fast, but that would also resolve after week 2. And the best part was that the 11.7 centimetre mass of lymph nodes in my chest and other areas was gone after just 2 cycles of chemo. I couldn't believe it. I said to the haematologist at the time, "Show me the scan," and sure enough, the areas that previously lit up on my PET scan no longer did. Happiest day ever. I even went out to the waiting room and did a little happy dance afterwards. I felt bad for the other patients in the waiting room, but I was like, yes. I went on and completed another 2 cycles, so I had 4 in total, to ensure that sucker was gone. While I was receiving treatment on trial, I felt so well looked after and most importantly safe. My treating team and haematologists were right outside the clinic door if we ever needed them while I was receiving infusions. I had a trial coordinator that I could contact any weekday if I had questions or needed something, and I could also call the cancer centre nurses anytime for their advice and their expertise. Yes, I had to do a few more scans, blood tests, questionnaires, but I actually didn't mind as it gave us all more information on how my body was going at any point in time. People would ask me, "Em, are you sure you don't want to go privately?" And I was like, no, because I felt so safe and well looked after where I was. Still now, as I'm in long-term follow-up, I can contact my haematologist or trial coordinator anytime for any concerns or questions. Yes, it's a bonus to work in the hospital where you were treated, as I can walk past my haematologist in the corridor and ask him a question. But he also said something real early on to me that really stuck with me. He's like, "Em, I'd rather you ask me a question than sit and stew on it until our next appointment. Less worry, the better." So why are trials important to patients? Well, before I answer that as a patient, I'll start with why I do my job for some context. As Judith has pointed out before, every drug or treatment that we use standardly today for any condition started as a trial. Each of them had to be tested, results obtained, analysed, published, and then approved by government bodies to be used in every general day use in medicine. And now I get to try new therapies on patients to help their conditions, and that might turn into the next standard of care treatment for that condition. I find that pretty cool. So as a patient, trials offer us access to new treatments that aren't readily available yet, access to new versions of treatment that may offer improved outcomes compared to current treatments, access to more targeted treatments, access to a team of specialists that keep a close eye on you and are there when you need them, and not only the potential of helping yourself achieve a better outcome, but also patients in the future. So if you're considering participating in a trial, see what options are out there for your condition. Consider the information available is a right fit for you. Ask every question you have, and if it feels right, it could be the best decision you make for your life. As now that I've been on a trial, I hope that my involvement will lead to other people having such a positive experience and great outcome. Thanks, everyone.